time. All right. Let me share my screen first before I close that out. Does anybody text her or anything?
I can.
Oh, yeah, no rush.
Obviously. Okay, so I have feline rhinotracheoitis because I have a devil child at home. So feline rhinotracheoitis, also known as FER, is a highly contagious upper respiratory infection in cats caused by feline herpes virus, which also by demon child has. It is the leading cause of upper respiratory infections in cats. This virus has been around since 1958. So the classification of this virus, I don't know none of those words.
You don't have to try, man. I don't think I can say that.
But yeah, those are all of the classifications. So the etiological agent, so the primary cause of feline rhinotracheoitis is feline calicivirus, also known as FCV. It is highly contagious that can cause mild to severe respiratory infection and oral disease. Chlamydia felis, which is C. felis, it's a gram-negative obligate intracellular bacterial pathogen, and feline herpes virus, FHV, which is also contagious that affects the upper respiratory tracts and the eyes in cats. So the virulence factors of feline rhinotracheoitis is the GI and GE of feline herpes virus, FHV1, are virulence genes that contribute to pathogenicity of feline rhinotracheoitis. GI and GE complex is quickly transported to the endoplasmic reticulum. The GI gene mutant is a mutant lacking the GI gene, does not produce the mature GE protein, which may remain in the endoplasmic reticulum. The GI gene and the GI gene C terminus mutant is a recombinant of FHV1 that lacks the C terminus of the GI gene that replicates slowly. So symptoms of feline rhinotracheoitis is sneezing, nasal congestion. It could be clear, yellow, or a green discharge, eye redness, discharge and inflammation, fever of 105, lethargy, loss of appetite, enlarged lymph nodes, mouth inflammations, such as sores on the mouth, tongue, or nose, and then corneal inflammation, which is No, I'm not. Keratotype. I'm not. Nope. I think it means inflammation of the cornea. So, risk factors of getting feline rhinotracheoitis is living in a multi-cat home. So if you have more than 2 cats, you have a higher risk of exposure. So cats living in multi-cat households are more likely to be exposed to the virus through contact with infected eyes, nose, mouth, or sharing litter boxes and food. Kittens and older cats are more likely to catch the infection. Cats that often are bored in or come from a sheltered environment are more likely to be exposed to said virus. Poor nutrition, stress, and poor ventilation can increase the risk of FHV infection. Cats with a weakened immune system are more likely to become infected, and then cats that are indoor, outdoor are at risk as well. So mode of transformation, the biggest is direct contact with an infected cat or contaminated objects. So direct contact can be saliva, eye discharge, or nasal discharge. Contaminated objects include food and water bowls and litter boxes. And then aerosol droplets pretty much when a cat sneezes. So to diagnose feline rhinotracheitis, you could do a polymerase chain reaction, and you can usually receive that result back within the week. The common diagnosis is that this test analyzes samples from a cat's eyes, nose, or throat for the presence of the FHV1 DNA. Medical history. So a cat's medical history and potential exposure to FER can help with diagnosis. So if your cat accidentally gets outside and is exposed to a cat that is feral and has feline rhinotracheitis, that is something that goes a part of the medical history. Clinical signs, a symptom of FER can include redness, swelling, crusting, and loss of hair. Antibody response is a virus neutralization assay can measure antibody response to the virus. It gives you a CBC, which is a complete blood cell count. It can check for secondary infections and other diseases. A serum blood biochemistry test, which is an IOF, can evaluate organ function. And then eye tests, specialized tests can check for dry eye or corneal ulcerations. So to treat this virus, you can use antibiotics, which prevent the secondary bacterial infection. Eye medications will treat corneal ulcers and prevent irritation from dried secretions. Antiviral medications may be used in some more severe cases. Intravenous fluids prevent dehydration from excess discharge. Humidification will help with nasal congestion. Nebulization, which is also known as an inhaler, will help remove hard secretions from the nose. Saline nose drops will help also remove secretions from the nose. An eye ointment can also help treat corneal ulcers. A oxygen tent is better for cats that have difficulty breathing. A feeding tube for cats who won't eat on their own. Strong smelling canned food stimulate appetite and help with dehydration. So that will go based off of prescription foods from Royal Canin or Science Diet or Peruvian Pro Plan and stuff like that. And then polyprenol immunostimulants, which is the only approved treatment in the US for FER caused by herpes virus. And also vaccinating your cats. And that's it.
Okay, so the respiratory tract, we know there's the upper and the lower. When we're talking about the respiratory tract, we really are a lot of these diseases defined by whether they're affecting the lower or the upper respiratory tract. And so upper being your sinuses, your mouth and your throat, and even including like into your ears, because those are really closely connected by the eustachian tubes. And so those can be affected by these respiratory infections as well. The lower, we're talking about the trachea, the bronchi, the bronchioles, and the alveoli. So all of the air sacs that are doing the gas exchange, the alveoli, if they become affected, you can't have gas exchange working as well as it should, and you'll have issues getting enough oxygen. For our anatomical defenses, we have nasal hairs to catch debris in the nose. The ciliated epithelium of the lungs helps move all the debris and mucus out. So you cough it up, and you can get it out by coughing it out, or you can swallow, and that will get rid of debris as well. And the mucus helps to trap things. Sneezing also helps to expel. Then we have our second and third immune defenses lines. These are complement action in the lungs. We learned about that. It's going to help poke holes in the bad guys, initiate your inflammatory response, and help with phagocytosis. That's the opsonization term. Then we have increased levels of cytokines, our signaling molecules, as well as the antimicrobial peptides and macrophages that are going to reside in the alveoli, called literally alveolar macrophages, that are stationed there to get rid of anything that could have made it that deep down into the lungs. And the secretory IgA, that's our class of antibody that's associated with mucous membranes. So it works better in the mucous membrane environment than IgG would IgG is mostly for the bloodstream. All right. I needed an energy drink because I thought I was gonna fall asleep today. And then now I had that. Now I just feel like all syrupy, like have like, you know what I mean? Like it's like sticky in your throat and stuff. Ugh. Now all I want is water. I drink a ton. Like you guys always see me with like my cup. It's tea, and I always cold steep my teas. So it's like I literally just ice water and I put tea bags in there because I'm lazy and I don't want to brew it ahead of time. But I drink so much tea, so now I'm just sitting here like this sugary. It's not even real sugar, but still I hate how it tastes in my mouth. I drink a lot of tea, you guys. It's ridiculous. I buy it in bulk. Like I buy like boxes of tea bags and it's ridiculous, but all different kinds. I mostly like the I get Bigelow brand is the brand that I buy. I like how their flavors go with the cold water. But anyways, I do vanilla caramel. But I usually prefer black teas, so and flavored black teas, and mint is my absolute favorite. So mint black tea is my favorite. Yeah. Mhm. Yes, I like, so the tea that I drink too, I want to be clear about this. I never sweeten my tea. So I only ever drink it unsweet. So people think I'm just insane for that, but
That's the only one I can do that with, is the cashew.
yeah,
Because it's strong enough. Some stuff is just too.
yeah,
I have to like have chicken express.
yeah.
Like so bad.
I don't really usually like a lot of sweet stuff. I put up with it with like energy drinks and like they even don't really usually have real sugar in them to begin with. And I still, even this is like super sweet to me. And I just don't really care for the sweet.
They have little mini ones that are the best. It's like the best size.
The Alani ones?
Yeah.
Yeah, I like those better. I don't usually buy this. My husband buys this for me. So. Okay, see, there you go. That would be better because then I would have something more mellow. I don't like how strong this one is.
Just through Mountain Dew over here.
Yeah, I can't do that.
Nothing against sugar, it's just something like tea, it doesn't.
Yeah, I don't know what it.
Bad for your reproductive health,
Oh,
though,
I
so when
know.
you decide to have babies, be
Oh, I
careful.
know, this is not a normal thing, I'm usually a sugar.
Look out, David. Yeah, I see that. When I need my sugar fix, I usually go for like ices. So anyways, so the respiratory tract, we have a good amount of biota that are part of your respiratory tract. I'm sure that you guys are aware of this. We have lots of microbes that live in your like sinus cavity, in your mouth, and in your throat. They're just part of your normal biome to take up your stadium seats and do the microbial antagonism thing, including bacteria and yeasts like Candida albicans. And these guys are just normal colonizers, especially at the upper respiratory tract. The lower should be less microbes though. We can have, especially in the upper, colonization in your microbiome with things that could potentially cause disease. And we consider these like pathogens in a lot of circumstances. Streptococcus pyogenes is the cause of strep throat and necrotizing fasciitis. It can play a big part in that. And toxic shock syndrome. Then we have Haemophilus influenzae, Streptococcus pneumoniae, and Neisseria meningitis, which we've already talked about are like our three main causes of meningitis. And then Staphylococcus aureus, of course, that can be colonized on your skin as well as in your respiratory tract. So you can be a carrier for any of these. It's normal to have some of these like in small numbers, like let's say in your sinus cavity, but if they get outside of those areas or if they overgrow too much where they are, then that's when they become a problem. We think that certain microbes you might have in your, just like with your GI system, if you have certain microbes in your GI system, it can throw off how other things function in your body. Certain microbes in your microbiome in your respiratory tract, especially your upper, can have effects on whether you're likely to get pneumonia and stuff like that later in life. All right, we'll start with a common cold. This is really a syndrome when we think about it. So when you have, you're sneezy, you've got a scratchy throat, you've got a runny nose, maybe a low grade fever, and you're just feeling a little down, that's a cold. It can be caused by over 200 different viruses. And that would include coronaviruses, rhinoviruses, RSV can fall into that category. Adenoviruses can fall in that category. Just all sorts of them. But they all have the same kind of symptoms, so we put them in the cold. Most people with healthy immune systems, you're really going to be sick for a few days and get over it. Certain viruses that can be associated with the cold can cause more severe symptoms if you have a lower immune system. But yeah, we don't really treat this with medications, just get over it. Then we have the sinusitis, inflammation of the sinuses. And we all kind of know what this is. At some point, you probably had a sinus infection in your life. This can be instigated by from having an allergy and then lead to a secondary infection from that. Or you could have some sort of other infection and it just progresses into sinusitis. So we know you're going to have that stuffy sinuses. You're going to have pressure in the face. Probably if it gets bad enough, you'll feel pain in your teeth. And it can even make your teeth feel like they're shifting a little bit if it's bad enough. That's not abnormal. It just means that you need to probably treat your sinus infection, but it's a common symptom of that headache. And you can have a yellowish or off color mucus associated with that as well. It's just a sinus infection. Yeah. And so I've had so many sinus problems before I learned that that was a thing. I used to think, because I've had so many teeth problems too, because I was telling you guys how I've knocked my teeth out like a couple of times in my life. As a kid, I used to play a lot of laser tag or ride bikes. I was very active. And I'd fall down or get kicked in the face or hit with a ball or something. And I've knocked out my teeth like 3 times or something as a kid. And then I've had to have dental work on like the caps if they would break or fall out later on in life. And so I've had a lot of dental work done, but then like I get sinus infections and I would just assume it was my teeth that was the problem because it would hurt. I'm like, teeth again, like it's my teeth again. And I go to the dentist and I'm like, yeah, your teeth are great. By the way, good job on brushing and flossing. Because I'm pretty good about that. Because after you've been to the dentist so many times for that much work, you're like, I'm definitely not having cavities be playing a part in this. Anyways, so but yes, so this definitely a lot of people, especially if they have particularly bad sinus infection, they don't understand that their teeth pain can be associated with that, especially like just the front top area. How swollen it is, that's crazy. I don't, so some of that stuff, I get interested in medicine for other people, but I don't want to know that that's what's happening in my own body, you know? Yeah, so most of the time, actually, your sinusitis is usually caused by viruses. Most cases aren't caused by bacteria, but if they are, it's usually secondary. You have some inflammation from allergies or some other viral infection, and then your own bacteria are what are causing your sinus infection. So they can be environmental, like fungal infections as well. Otitis media, this is an ear infection. It's usually you have some sort of cold or you have some sort of allergy, whatever. Your eustachian tubes that drain like fluid between your ears and your throat become inflamed and you can no longer drain the fluid anymore. And then normal bacteria in those areas or bacteria introduced from other people potentially will overgrow whenever it can't be clearing the fluid well. So the fluid will build up in the eustachian tube where it cannot drain, and then that will back up behind the eardrum and can cause rupturing of the eardrum and permanent hearing damage if it's not taken care of expeditiously. I don't think I've ever said that word out loud before, but it just popped in my brain. There you go. We kind of get an idea of what this would be like, that fullness, pain in the ear, irritability for children that don't really know how to express their pain very well. They'll just be irritable, have trouble sleeping or eating because they're not feeling well and all that. So you want to, if you think a kid has an ear infection, give it 72 hours, see if it improves. And then if not, go take them to the doctor. And then you can get tubes put in to help drain the fluid, to help alleviate the pressure to hopefully prevent any permanent damage. Most commonly, if it's bacterial in nature, it's going to be strep pneumoniae again. So we're already having this pop up once in this chapter. We've already seen it previously in other chapters. Strep pneumoniae, the pneumococcus associated with pneumococcal meningitis. And we're also going to talk about it, obviously, with its name, pneumonia as well. So we also have Candida auris, like thinking of something being like auditory. This one is mostly associated with the ear infections, this type of yeast. It's not communicable. It's usually just secondary to other things. Yes.
So, is it still considered like a true ear infection for like swimmers' ear?
I guess it depends on how it progresses, because swimmer's ear is more like a term that we use for like symptoms associated that you're having like after swimming. So if there's an infection involved and it's actually truly like in the ear itself, then yeah, I mean, you could see that it could come from irritation from the water getting trapped in there and then leading to an infection, but not always. So if it's outer, because a lot of times it's just outer irritation from that, and then the water can't drain out, but that can resolve on its own. Like my mom grew up on a lake, right? And so her mom learned how to like help treat ears that would get like lake water in them all the time. So alcohol and something that's water, alcohol, and God, I think I want to say it's hydrogen peroxide, but that might not be right. Anyways, she had this solution that was for, what was it? I think it is, yes. And so that helps soften earwax, by the way. If she'd have a solution of that made up for like the kids, if they went and swam, like they had to swab their ears with that to prevent swimmer's ear from happening, from trapping the water in there. The alcohol helped dry it out faster, but yeah. Yeah. So to be clear about ear issues, guys, I talk about knocking my teeth out. Let's hear about my ears for a little bit. You heard my sinus infections. You've heard about my teeth knocked out. My ears. I have such tiny ear canals that I can't fit Q-tips in there, even if I force them. I can't even force them in there. And I go to the doctor. One ear I can fit it in this one, like if I really like push it, but like the other one I can't even. I go to the doctor and she's like, your ear canals are ridiculously small. And I used to get problems with earwax because everybody clears out their ears with Q-tips, and it ended up I was just forcing it in there further, and it would impact the wax. So I just stopped. I'll like clean out the outside of my ear, but other than that, I let my ear do its own thing. I've had no problems at all with earwax now. They're not kidding about that, like not cleaning out your ear wax. Because if you get used to cleaning it out with the Q-tips, then your ear tries to compensate by making more wax. Because it's like, what are you doing? I'm trying to keep this place like so that I can catch all the debris, and that can actually make it worse. So that's a true thing too. I just had to learn that because I can't fit a freaking Q-tip in there. Yeah, I can. I can hear just fine. When I was younger, I would have issues with hearing, and that's how I started learning about this. Is because my doctor would be like, "Listen, stop using the Q-tips. You're blocking up your hearing," and it would be like to where if I even tried to use Q-tip, I would like be completely blocked off from hearing for like, and that made me panicky because like whenever you like can't hear it all out of one ear, and you're like, "I know I'm supposed to hear," and I had a bad habit too when I was in high school. Like if that would happen, that I would try to get the earwax out with like a paper clip or something like that, and then I'd get infections in the ear canal, which was easy to treat with antibiotic drops. But then my mom would be like, "You've got to stop doing that." So that's how I learned about the hydrogen peroxide thing. You can also use like Dulcolax stool softeners, the liquid gels, and put that in your ear, and that'll help get the earwax out. So if you have issues with your kids with that, Dulcolax in the ear, let it sit for 30 minutes, and then warm water with half warm water, half hydrogen peroxide, and just use one of those nasal things to squeeze in that water just really gently and let it flush out the earwax, and it'll like clear it up. That's what the doctor will do too, unless they use those little tools to scrape it. But yeah. It'll align it and help it drain. Yeah. Yeah, you can do that too. So I learned how to do that pretty well to take care of my ears. Now I don't have any problems because I can be an adult and be intelligent enough to know that I was being stupid trying to clean it out. But yeah.
Q-tips feel so good.
They
I
do.
get why people do it. I just
Yeah. So on the one ear that I can do it with sometimes, if I take a shower and everything's nice and
open.
yeah, then I can get in that one ear and it does feel cleaner afterwards. And like my husband has giant ear canals, and she's like, "It's so great. You know, how do you get your ears clean?" And I'm like, "They are. Right. They're fine. They're doing their thing." Anyways, pharyngitis is inflammation of your throat. So your pharynx is your throat, and this can be viral or it can be bacterial. We're going to talk about the bacterial ones because the viral ones can be a whole ton of viruses, and it's much milder symptoms with the virus. Bacterial, more severe. You can have fever. Either of these can have a foul breath. They can have nausea and headache and fever, but it's just going to be more severe with the bacterial. The two bacteria that we're most concerned about are Strep pyogenes and Fusobacterium necrophorum. So Strep pyogenes, we've learned about this, man. So strep throat is what we're going to talk about today, but we've introduced this with other concepts like impetigo and necrotizing fasciitis and stuff. But gram-positive, it has a capsule or slime layer, helps it stick to things, helps prevent phagocytosis, and it makes some toxins that help it do its job, breaking into your extracellular matrix and getting deeper in your skin. Fusobacterium necrophorum, this guy is associated with trench mouth, which we'll learn about a little bit in the next chapter. But this is a bacteria that some people have in their normal biome in like their mouths or whatever. And then if it gets out of control, if you're not keeping up with oral hygiene, it can get pretty bad. But it can also cause peritonsillar abscesses. So if you have tonsils and you get these abscesses like behind them, they can actually rupture, or you have bacteria enter your bloodstream. This can become life-threatening if this does happen. That's called Lemierre's disease. Next is whooping cough, also known as pertussis. This is part of your TDP vaccine, your tetanus, diphtheria, and pertussis. I cut diphtheria out of the class because we don't see it as much here in the United States anymore because we vaccinate so well for it. But diphtheria is bacterial too. It just creates a pseudomembrane in the back of the throat that can literally close off your ability to breathe. So it's kind of terrifying, but we just don't see that as much here. Whooping cough though, the 3 phases of whooping cough, you will get tested over like what these are. There will be a question, at least one, about the 3 phases of pertussis. So the first phase is the Cotterell phase, where you have cold-like symptoms. Once you start coughing, you're in the paroxysmal phase. In the paroxysmal phase, I don't mean a little bit of coughing. We're talking like incessant coughing that leads to hemorrhaging in the brain, vomiting, ruptured blood vessels in the eyes just from coughing and coughing and coughing. We're not talking a couple days. They call this the 100-day cough for a reason. I mean, maybe not literally 100 days for everybody, but it is a cough. So this is really, really bad. It leads to damage of the lower respiratory tract cells, including the cilia that are supposed to be moving everything out. They'll completely obliterate them just from the coughing. And so then you're susceptible to secondary infection. So in the convalescent phase, even though you may have cleared out pertussis bacteria and your body fought that off, now you're susceptible to secondary infections for months afterwards while your body recovers. This is a little video of a baby, and we're gonna let it play for a little while to give you guys an idea of what it's like for little babies who get pertussis, which is where we see this primarily here in the United States, because you don't get vaccinated for this until like you're 6 months old, I believe. It's at least 6 months. So little babies are more susceptible to this. Adults who don't keep up with their vaccinations can be carriers for it and not know that they have this. You might have like mild symptoms. So you would see your grandbaby in the hospital and give your grandbaby pertussis, and then this can happen. I was gonna warn you, there's gonna be an ad. I can't get out of that part. You guys wanna get some new tires? So you can see how long this video is. We've only gotten 45 seconds into it, and it goes on like that. So this is pretty much how it is. If you're a little baby that has whooping cough, you have very few breaks in between these coughing fits. If it's mostly you're going to be coughing. And it's so bad with little babies, they don't understand the importance of making sure you take a breath. And you see this baby struggling just to take a breath, and you can see how easy it can be to become hypoxic or something just from not breathing enough in and just coughing to try because of the feeling of needing to cough. So it can be very serious and have serious side effects because of that aspect of it, plus any issues that could be associated with having secondary infections. So hold on, let me click on this. All right. So this is caused by the bacterium Bordetella pertussis. It's gram negative, and a lot of the effects of this inflammation in your lungs and all that's making you need to cough is the endotoxin because it's gram negative, and how the other toxins that it's going to be making literally causing massive amounts of mucus production that you want to clear out, inflammatory reaction from the endotoxin, destruction of the ciliated cells themselves with other toxins. We do have vaccines, obviously, like I said. If you're getting your booster for tetanus, this comes with it. So as long as you're keeping up with your tetanus vaccine, you're keeping little babies of the United States protected. Next is RSV, another one that can lead to cold-like symptoms in adults and people with healthy immune systems. If you have a low immune system or if you're a little baby, 6 months or less, this can be very dangerous. The high fever will come with a younger age, and then there's all sorts of issues associated with having a high fever. So you can have more serious disease. We saw a significant decrease in this, as well as flu during our COVID epidemic, where we all had to mask up and do social distancing. Of course, then this would decrease, and so would the flu. So it just shows you ways that you can help protect from that if you were concerned about that. But RSV stands for respiratory syncytial virus. The syncytia, we remember that viruses are basically, they have a membrane or they don't. But if they have a membrane, there are spikes on the outside will come interact with the host cells. How does he not know I'm at work teaching right now? It's like literally calling me, and I'm like, what do you think I'm doing, buddy? Like 2 or 3 times he called me in the middle of the review. I'm like, great. And like, I literally texted him. You guys didn't see it, but the text message I sent him just said, in a review, leave me alone. And that's like what it said. And he came home in the middle of it too. But anyways, right. So syncytia. So your virus, your membrane, your spikes are your key to get into the host cells. And then you merge your membrane with the host membrane and dump your contents inside. Well, when you're infecting that cell, what do you do with your new spike proteins that you're making? You put them on the outside of your host cell, right? And then you will bud out and cover yourself in like a little blanket. And new viruses have the membrane with the key to get in the next cell. The problem with that is if you have your host cell and you've got all your spikes on the outside getting ready to cover your virus, those spikes are now on the outside of that host cell. And the one next to it could see that and interact with it as though it were a virus getting into the cell. So the cell to cell interaction from those spikes. And that causes those membranes to merge. And now we've got like cells merging with each other. And that is what syncytia are. So you have several multi-nucleated blobs. They used to be multiple cells. And that's what syncytia are. And that's pretty common with several viruses, but this is a pronounced effect of this particular virus. Causes cold-like symptoms. You know, have a fever about 3 days. Typical sort of cold symptoms associated with it. It's pretty transmissible. Very, very contagious, but it is treatable with ribavirin. Again, more of an issue for infants. Flu, now we have the different kinds of flu, usually defined as flu A, B, or C, and then you can have H1N1 or H5N1 or H1N5 or H2N3 or whatever the heck, right? And that's how we'll define it. The flu is caused by influenza. And so this is not a syndrome like a cold is, right? This is caused by one virus, kind of like the plague is caused by the one bacterium, and pertussis is caused by pertussis, right? So the flu is caused by the flu. If it's caused by something else, that is not the flu. You'll have headaches, chills, cough. It's usually a dry cough, body aches. Fever is almost always associated with the flu, and it's much higher than what you would see with any sort of cold virus. And this can be leading to severe fatigue that can last a few days or weeks, prolonged, but you don't see that with the cold either. You can get secondary infections that can be common. That can lead to pneumonia. Flu itself can also lead to pneumonia. This is an image of the flu virus. Here we have these little like things on the outside that are going to be our hemagglutinin and our neuraminidase and some other things for the virus we don't need to worry about. But we look at these little worm guys in the middle. These are the genome segments. So like we have multiple chromosomes. This virus is a virus that has more than one piece to its genome. It has 8 segments. And these segments are important because they're what carry the genes for the virus, of course, but they also help us identify what kind of virus it is as well. We'll get into that in a moment. So on the outside, we have the H and the N. It helps us define like what kind of virus we're dealing with for as far as flu goes. Hemagglutinin, agglutination is like sticking together. So hemagglutinin, we're sticking to red blood cells. We're also sticking to other tissues in the body, especially in the respiratory area, to help get into the respiratory system, those cells. So hemagglutinin is our like entry, the spike that lets us get in. Okay. Neuraminidase, ACE being enzyme. Neuraminidase, this is going to be an enzyme that helps break down that mucus coating in the respiratory tract, helps the virus get in better. Doesn't get it stuck in there, so you can't get it out as easily by coughing and stuff. It also helps clip off the budding viruses, but it also helps to get into the cell by helping with the entry mechanisms as well. So it does a lot. So there's 2 ways that you can get new flu viruses and why we need to keep getting new vaccines every season. The 2 ways that we have are drift and shift of our antigens, our H's and our N's, okay? Drift, imagining that you are drifting, you got in a plane accident, whatever, you're one of the lucky few that got out, or a boat accident, you have your little life raft, but you don't have any oars to paddle with or any motor. So you're gonna just drift with the current. You're at the whim of nature. So drifting for this virus is like that too. You're at the whim of nature. Your mutations that you'll make just randomly from multiplying, eventually you'll get beneficial ones, and those will help the flu virus change to where it looks new to your population that you'd be infecting like humans. When that happens, you get a new strain that you need new vaccines for, and you get sick again next year, and that's bad. But you also have shift. So shift is like when if you want to shift your position in the ocean without being dependent on nature, oars or motor or whatever. So you have some help here. Shift is where you have a blue virus and an orange virus, maybe one from a duck and one from a person on a farm, okay? Person has the flu, duck has a flu. Normal flus for those guys. The pig gets infected with both, and now the virus that it spits out is a mixture of the 2. So now you might have had H1N1, and you might have had H5N5, but now you have H1N5. for example. This reassortment of those segments, you can kind of pick and choose. And this is what leads to new pandemic level changes in the virus. So big changes. So you'll need new vaccines for sure, but it's also something that your body really has never encountered anything like that flu. And so it'll have more severe symptoms in your body because aspects of it that your immune system has never seen before. So the shift, this is how I remembered it. Yeah, okay, we have the drift and the shift like explanation, but there was like a semester, like my second semester teaching here, that I had this figure up and I was writing notes on it and I was saying antigenic shift, but I wrote shit instead. And man, if pigs aren't covered in shit all the time on a farm. So pet pigs, you can keep them clean, but farm pigs are not. So that's how I remember this is the one that happens with the reassortment in the pig, getting infected with the two viruses and making a new one, okay? All right, so we know how this is transmitted, but we hear all the time that if you go out in the cold, you're gonna get sick if you're out in the cold for too long. Obviously, the cold doesn't make you sick, right? Cold air doesn't make you sick, but what it does do is dry out your mucous membranes and cause inflammation as a result and make you more susceptible to getting sick from other people. And so it seems like people get sick from the cold, but they're actually just making themselves more susceptible to being sick. So cold air is an issue. We do have vaccines available that we have to change for the season to accommodate those drifts and shifts. And we can predict what we're going to see in America to try to prevent it altogether. But unfortunately, there's so many different strains that you can see even at one time, so it can be hard to keep up with. We're trying to make a universal flu vaccine, but it's just hard because of how much gene reassortment there can be. Next, we have tuberculosis. This is an old disease, like underappreciatedly old. Mummies in like Peru and in freaking Egypt, and even from the Stone Age have been found with tuberculosis. We're talking about like almost prehistoric times. So we developed antibiotics in the 40s, and then we saw a steep decline in the seriousness of presentation of tuberculosis. But now it's reemerging because of the HIV epidemic, because we have resistant strains. And it turns out about a third of the world's population is infected with tuberculosis right now, which is pretty impressive, almost as impressive as that South America number of people who have HIV, which just is terrifying every time I think about it. Obviously, we know this one. We've been talking about it since the beginning of class. Mycobacterium tuberculosis. So it's mycobacterium. We know that it is acid-fast. If it's acid-fast, it has to be gram-positive. Acid-fast bacteria, that mycolic acid is a wax that makes it really resistant and hardy. And so it can actually be one of those things where if you have tuberculosis right now in here, and you were to cough a little bit, the bacteria can get released out into the air and hang there for like 8 hours. And so they're pretty resistant to that. They're resistant to drying, and some chemicals are pretty resistant to it. It only takes 10 bacteria to cause an infection. So we have 2 stages of tuberculosis, primary, and then, well, there's 3 technically. We have primary, then latent, of course, because that's going to be your in-between, where it's just chilling and nothing's going on. And then secondary or reactivation tuberculosis. And that's usually the one we think of when we think of tuberculosis, okay? So you get your first infection, and you form these tubercles. And the tubercles are basically large granulomas where your body's trying to wall off the infection. And mycobacterium is pretty aerobic. And what it'll do is it'll get eaten up by your alveolar macrophages, and it's actually where it likes to be. And it'll live just fine in there and get all of the nutrients that it needs and the oxygen that it needs within that cell and be fine. But if you wall off those macrophages that are infected, as well as bacteria that are in the area, with other white cells, and you block off oxygen to the area, the stuff inside of the walled off area, the granuloma is what that's called, will die and become necrotic. And you form these caseous lesions. Have you ever heard? We've been talking about casein, right? Being the protein in milk. That's what leads to cheese being cheesy. Caseous means cheesy. This is where this gets so gross to me, like especially when you look at these lesions here. But yes, they're necrotic, cheesy, caseous lesions, and those eventually will harden over time and become calcified. So that'll sit there like that and exist in your lungs like that, and you might not have any symptoms, but we can still diagnose you with tuberculosis. And one way we'll do that is with your skin test. We've talked about this. It's a delayed hypersensitivity type 4. If your T cells have ever reacted to those intracellular guys, then you'll have them activate within a couple days after seeing that skin test. And that's how we'll know. We'll do a chest x-ray and we can see that you have these granulomas and calcified lesions, those tubercles in your lungs, even if you're not having symptoms. And you can live like that for a very long time. Your immune system starts to wane though, and now you have presentation of the symptoms of the reactivation of this, because now you've got all of these caseous or necrotic or calcified lesions in your lungs, but the bacteria are wanting to come back out again because they're not being contained by the granulomas anymore. So you have all this damage already existing and then spreading more damage. So this is consumption. So when we think about proper tuberculosis and coughing up blood and losing weight, wasting away and all that, consumption. So you will cough up blood and greenish sputum. The green is usually from blood cells being broken down, that hemoglobin breakdown. Low-grade fever can be associated with this. Anorexia, you just don't want to eat anymore. Your body is like focusing on other things. Weight loss associated with that. Fatigue, night sweats, and of course, chest pain. If you don't treat this, it's a 60% mortality rate, but we do have antibiotics available for that. We've already talked about how it's acid-fast, gram-positive. It's a strict aerobe, and it's a little slower multiplication compared to other bacteria, but for mycobacteria, it's actually very fast replicator. These guys usually take weeks to double. So tuberculosis itself as a disease is technically a syndrome. It can be caused by Mycobacterium tuberculosis, the obvious one we're used to. We've also seen exact same presentation with Mycobacterium avium complex, just several strains of Mycobacterium avium. And that's usually associated with AIDS, but it's the same presentation. Here's our acid-fast stain. You guys already know that the reddish pink cells here are going to be our positive cells, and the blue around it, those are our negative, just probably your normal microbiota and stuff in the sputum. Transmitted through fine droplets in the air. We have it all over the world. It's usually associated with close living and factors that can make you susceptible to it. Inadequate nutrition, decreased immune function, poor access to medical care, having prior lung damage, being a smoker, having emphysema, having had pneumonia, something like that. And then of course, genetic predispositions. We have our skin tests, antibody tests, and PCR to confirm each other, as well as the chest x-rays. If you have active tuberculosis, we can help treat you. If it's not active, it's going to be so walled off, we can't treat you because we just can't get antibiotics to those areas. So for active tuberculosis, you'll have 2 months of rifampin, isoniazid, ethambutol, and pyrazinamide. I don't know much about the last two, but I know that they will cycle you through these for a couple months, whichever one showed the most promise, or the top two, one or two, they'll provide those to you for the next 4 to 7 months until you're free of the bacterium in your lungs. 6 to 9 months of antibiotics. So you can imagine why people wouldn't adhere to that, especially in rural areas. This is a huge, huge problem in areas where HIV is rampant, like in sub-Saharan Africa. They're just not adhering to their treatments. And so drug resistance develops and they're not getting rid of the tuberculosis, it's just getting spread around. It can get into other organ systems of the body and not just respiratory tuberculosis. You can get it in other areas too. Next is pneumonia. Pneumonia, here we have an infection in the actual pneuma or the lungs. The inflammation associated with this draws the fluid and the white blood cells in the area to try to fight the infection, but that fluid builds up in the alveoli, and that's where we start having problems getting enough oxygenation to the body. In order to cause pneumonia, you need to be either be able to avoid phagocytosis, being eaten up by our white cells, or avoid being killed by the macrophages that eat you. Like tuberculosis, they like to live in there. So they're not the only ones that do that. So usually viral pneumonia is less severe than bacterial pneumonia, but not always. And then fungi can also cause pneumonia. So we have all sorts of things that can be contributing to these signs and symptoms, making this another syndrome. Right, so you usually start off with presentation of cold, maybe flu at first, and then we'll have the lower respiratory tract getting involved. So chest pain, fever, cough, discolored sputum. The fluid will build up in the alveoli. You'll start to get pale and look sickly. And then you have a very quick onset of worsening symptoms if we can't get that controlled quickly. And it can be worse and worse depending on what everything is causing your illness. Of course, there's a lot of different things that can cause it. So community-acquired pneumonia is usually caused by our good old friend, the pneumococcus, streptococcus pneumoniae. That's where its namesake is from. So it's gram-positive. About 50% of people just carry this around in their normal respiratory tract, but if it gets out of control in the lungs is where we have presentation of pneumonia, usually secondary to some other infection and the inflammation that is associated with that. So you either inhale it deeper into the lungs where it doesn't belong, or you got it from somebody else. It's usually associated with something else that might be lowering your immune system, whether you're sick with something or you're taking like a steroid or something like that to make you more susceptible. And these guys are going to have ways to prevent phagocytosis, like by blocking complement and causing fluids to build up in the lung by certain toxins that they'll produce. We do have antibiotics to treat that. Atypical pneumonia that doesn't quite match the same symptoms as our typical pneumonias like pneumococcus causes. Atypical pneumonia or walking pneumonia is caused by mycoplasma species. So specifically, more commonly, Mycoplasma pneumoniae, go figure. Mycoplasma is like you're carrying a cup of plasma that doesn't keep its shape when you spill it. They don't have a cell wall. They don't keep their shape either. So we call them pleomorphic or irregularly shaped.
Like, are you less sick?
Yeah, you have less, you're less affected by that inability to get oxygen, but you still have pneumonia. Yes. And so it can be actually longer lasting. It's more like a chronic version. I don't know. Yeah, I'm so concerned about World War III that I haven't even thought about anything else. I don't know. I don't really keep up with that stuff. But if you hear anything about it, shoot me an email. It probably is. It's really common. I will say that. Like walking pneumonia is actually pretty common. What? Maybe. I mean, and that's the thing. This is my work, right? So I don't know, but and most of the time, my students that come in here, they're sick. They're like, I mean, I'm sick. I don't know. Like that's they're like, I'm sick with something, or they won't show up and they'll be like, they'll be like, I'm sick. I'm not coming in today or whatever. And that's fine. You guys do you go how you want to. If you get test positive for COVID, though, please stay at home. That's all. And I don't know. I'm sure you guys are probably good about it too. If I start feeling sick and I feel like it could be COVID, I always test just to be sure so that I'm not getting other people sick. So it's always good practice. It's cheap enough now to buy the home test. There's no reason really not to. Now you can buy those home tests that have flu in it too. You can test for flu and COVID in one test now, which is really cool. They sell them at CVS. I saw it last time I was getting a prescription. When you can get like a home pack of like 2 or 3 flu tests for $20, yeah.
But if you have to know from someone, then you're stuck with that.
Yeah, that's what sucks. That's what whenever people start to work in at hospitals though, and then they know the doctor.
Yeah, exactly.
I mean, nope. Yeah. So they're not as accurate. I'll be honest, but
I can see if it's negative, not really believing it's negative, but if it says that
if it's positive, it has to be positive. Yeah, it's not a false positive. Yeah, you can get false negatives with those, but you won't get false positives. Yeah. That was with my dentist. So the first time I had to have an apicoectomy, which is where they drill in, like if you get a root canal and it doesn't take, that means it's deeper than the root canal can get to. So it'll be like in the bone. So I had an apicoectomy because my infection just wasn't clearing. I had like 4 root canals in that tooth and it just wasn't clearing, right? And so they were packing it with antibiotics and all this, and they're like, we're gonna have to do this. Ended up the area was way bigger than they thought it was. It's like somewhere around like silver dollar size or something. And they anyways, so they had me go in there and they're like, here, take a couple of, they gave me like a children's like NyQuil or something. And it wasn't even like, it was like literally like a children's NyQuil from like a NyQuil bottle, like sitting right there on the desk, like a little like cap full of it. And that was my sedative. And I had my headphones on literally as loud as they would go. And so he's injecting like my Novocaine shots into the bone in the top up here and getting that in there. And like he starts to getting to work in on like the drilling. And I'm like screaming. I'm like, this hurts. And he's like, it doesn't hurt. You're just feeling the drill. And I'm like, no, I am not. And so I'm like arguing with him and he's old, right? Like he's like 77 and he's like, right. And so he's like, he was an emergency dentist. I didn't really have a whole lot of choice at the time. And so it's like, I was brand new. I was living in Philadelphia. I was only there for a week. So I was just like, I needed something because of pain. And so that was what had to happen. And like, he's doing that. And so he gets mad at me and starts yelling at me and be like, you're unbelievable. I've given you like whatever many shots of Novocaine. And you cannot tell me you possibly still have pain. He's throwing a tantrum and he's leaving. And like the dental assistant is there. And I was in there like crying and whatever. And she's like, he gets this way, some people, and she's smart. Like she's like, when you get infection, it's really hard to get the Novocaine to the nerve because everything's inflamed and you don't get good effect. And that's a smart person. And so whatever. So he calms down, like 10 minutes later, comes back in and gives me more Novocaine. And it was fine after that. Except I had no sedative. I had to lay there for like, I think it was like 2 hours or something with drilling going on in your bone. And there's no hiding that sound. It was the most traumatizing experience I've ever had in my entire life. And never again. It is. Yeah, believe me. So I don't have a regular dentist anymore because it's like everywhere I go that is in my like like my insurance or whatever, I'll be like give them a couple tries and I'm like, you know what? I'm gonna go see somebody else. I shop around. And so I get my cleanings, but it's never usually with the same people. You definitely email me because if you trust the dentist that you work for, then I trust that that's probably, yeah. Yes, send me the info because I'm looking for a more permanent solution. Because when I was a kid, I had an amazing dentist. He was great. He was good with kids. He was patient. I went every 6 months and like was good about going. Never had a single cavity until I got old and it was my very, very, very back molder and molar. And that was like not surprising. Like that's where you are more likely to get because you don't brush very well back there. So that's the only cavity I've ever had in my whole life. And so ever since then, I'm like, I take really good care of my teeth. I brush and twice a day. I floss every day. Like I shouldn't have to deal with crappy dentists on top of that. Like that's ridiculous. If this is what the good patient, the attention they're getting, what are these people that have actual like dental issues dealing with? Anyways, that made me think of that, the old man situation.
When he told me what he had to do to get into medical school, I was just like, oh,
Right.
I'm 77 now. So
Right, so you
could've
could have been
more
that guy. All right, so anyways, moving on. Legionella pneumophila. This is a bacteria that is, we don't see this as common as like a communally acquired pneumonia. This is like what we get from the building that you're in being shitty. So this comes from like water cooling towers, maybe like water taps and like hot tubs that aren't being maintained well, or just fresh water situations. So these are moist environments. This is not a mold. This is going to be bacterial, but sick building disease. So you can have buildings having situations like mold or bacteria that flourish in damp environments causing pneumonia. So whether that's black mold from the toxins they produce, or you're actually getting sick with the mold, or you're actually getting the bacterial infections, that's sick building disease. So Legionnaire's disease is one of those. It was like a convention with some old guys, the American Legion convention, and a bunch of old guys got sick. And it turned out it was this bacteria associated with the cooling tanks of that building. You don't see it a lot though. The next two are fungal pneumonias, and I'm not going to go into them too much, but what you do need to know is they're fungal and that they are associated with AIDS. So that is Histoplasma capsulatum and Pneumocystis jirovecii, especially pneumocystis causes pneumocystitis, fungal infections. These guys are AIDS related, typically. You can get this as older aged individuals as well. You also have healthcare associated pneumonia, associated with being hospitalized in a healthcare setting. About 1% of people who are hospitalized, so admitted to hospitals, will develop pneumonia. 50% of those people, 30 or 30% will die from that. Right now, that's the current statistic here in the United States. So that's usually going to be caused by multiple microbes all at once. And our common list is going to be things that we see pretty much everywhere. MRSA, super common, flying around in a hospital. Klebsiella pneumoniae, Enterobacter species, and Escherichia coli, Pseudomonas aeruginosa, and Acinetobacter. All these are just like around, and most of them are enteric bacteria, so poopy hands. So these getting into respirator situations are the common cause of these. So tracheostomy tubes and intubations, things like that. A lot of our patients that are getting this might be unconscious, so there's not much they can do to help with that. But you want to elevate your patient's head. If they are conscious, encouraging coughing and deep breathing to get oxygenation going to help clear out infection and prevent it. And of course, maintaining clean equipment. Antibiotics will also help treat it. Next, we have hantavirus pulmonary syndrome. This is here in the United States. It was started in New Mexico, but it's pretty much all over the West now. It's an emerging disease, pretty new. We saw it started in 1993. 33% mortality rate, and this is usually found from the droppings of like mice. So like deer mice and or whatever, they come in, field mice, they come into your house, they poop and pee, you're sweeping up, and the dust of that gets into your lungs and you get hantavirus pulmonary syndrome. It can also lead to a hemorrhagic fever if it gets into the bloodstream after that. Prodrome, which is our early symptoms. first symptoms you'll see, these are going to be just you're sick. And then it'll develop into the respiratory aspect where you'll have respiratory distress and then severe respiratory issues leading to potentially shock or hemorrhaging and viremia. So again, it's airborne from the droppings from these rodents. There are no treatments for this. And then here, again, 33% mortality rate. It's not super common. And these are the cases that were reported in the United States. Here we can see it's mostly in the West, but it's not a whole ton. I think this is all of them, not like the last 10 minutes or something. This is like all that have been recorded so far. So it's not super common, but it isn't something you want to get. All right, that's our respiratory diseases. Here's a little chart. We'll go through the questions again. I won't call you out. We'll probably call you out next week though, because y'all don't have, or when we get back, because y'all don't have lab. So I'm just saying. So, but today, Fusobacterium necrophorum, our respiratory disease associated with this is going to be our throat pharyngitis. So that was the peritonsillar abscess one. What organism causes whooping cough? This is Bordetella pertussis. It's a bacterium. Antigenic shift in influenza. Remember, shift is where we have reassortment of those gene segments to create novel strains that are like brand new to us, like instead of H1N1 and N5, you know, getting like a mixture of those. Whereas drift is just random mutation aspects to it, it's a little less severe changes. What type of organism causes tuberculosis? This is a bacterium. Remember, Mycobacterium tuberculosis, it's in the name. What is the most common cause of community-acquired pneumonia? So community-acquired, just normal population, not healthcare. That's Streptococcus pneumoniae. Okay. All right, that's that. So we're, before we get all, we can guys start packing up if you want to, but we're gonna go up to the lab. I need to set up some of the tubes. They just don't hold up sitting there for a little while. So I have to get the tube out, add reagents, and make sure everything looks nice for you guys and turn on the microscopes and everything. So you know the rules. Don't move the microscopes, but you are welcome to adjust the fine adjustment if they got bumped or something. If you can't get it to focus, please call me over. If you have any questions about wording on the test or what I'm trying to refer to with the question, it never hurts to ask. I might just be able to reword it for you and make it easier. There's no point in stressing yourself. There's a couple questions on the test that are stressing people out. One of them has to deal with one of the staining procedures. Again, most people are focusing on the last part of the test and thinking that the first part is just refresher and whatever. But our stains are not just going to be primary, mordant, decolorizer, and counterstain. Sometimes our stains, like our primary stains, can be different kinds of stains and how that they interact with the cells. And I'm just going to leave it at that, but there might be other descriptors besides just being a primary stain that we can apply. The other one that people are having an issue with, and I'll show you when we get into lab so this is clearer, but you guys know your first page of your unknown report. Let's bring one up that so I can give it as an explanation, because I feel like if I can show it to you here, then when you see when we get there, you will know what I'm talking about. Okay. Gosh, I thought I was just gonna pull the thing up. I hate having to log into stuff. So my apologies if I'm pulling up somebody's lab thing that didn't get 100. Almost nobody did get 100 on it for me. Are you serious with the freaking dual pushes today? It's not even pushing it. Anyways, the chart on the first page, you know how it's all like, oh, your stains, positive or negative, and then the tubes, positive or negative. And when you use your key, you guys know how to actually use the key? You say that now. Okay. But you and I know you can look at the chart. It has all the info you could possibly need and beyond to identify your organism. You look at the chart, it's for your gram positive. Great. You start with gram positive. On our chart, remember how it said our key. You know how the key says cocci or bacilli. And then if it's cocci, you would select catalase or no catalase and that, right? And you guys know how to follow that. And that seems pretty normal when you're looking at your little chart thing. There's another question that is the exact same asking for the gram negative that I don't give the chart for. I just list there were positive tests and these were positive and these are the negative tests. And it's not on the chart. It shouldn't matter. You still use the key the same way. So if it says negative, what was our question for the negative? It was gas and glucose or no gas and glucose.
Oh, so just the name of that specific one is not on the chart.
That's not what I'm saying. So what I'm saying is like, I will give you a question that'll say, there's an organism I need you to identify. it was gram negative, and it was positive for urease, and it was positive, I'm just trying to think of all the tests, malonate, urease, citrate, it was positive for those. It was negative for glucose fermentation and something else, right? And that's all you get. And it might be a ton of information, way more than you would need to follow on your line to get to your answer of, you know, Haemophilus influenzae or whatever. So just remember, you use the key the same. So if the key, it doesn't matter if it's a whole jumble of words or nice in a little chart. You still use the key the same. You start at the left where it says gram negative. If it's gas or no gas, that's all you look at in that step, is gas or no gas. Then you can move on to the next thing, this or that. Then you can move on. Don't just say, oh, this has indole on the name. Okay, was it positive or negative for indole? Oh, it was negative. But you didn't look at the other factors. Why are you even looking at indole now? You get what I'm saying? Do it from left to right.
The answer is still on the chart. You don't just have to remember that this was negative for this and this was positive.
Yes, I'm giving you the key with the names on it. I give you the key with the names. I'm going to give you the results of their tests. But you have to tell me what the organism is from that. It should be easy. It really should. But for some reason, not having it on that chart has like even Becky herself was having a freaking conniption over this. And it shouldn't be that way. It's just the same.
I'm going slower this time. I'm planning to go back to stations because I did